Session of FCPC. Today, the session will be on pain and its impact, and it will be taken by Dr. Aju Mathew. The first 40 to 45 minutes will be the presentation, followed by a discussion, and then we'll be having a case presentation by Ms. Alpa, and it will be for 10 minutes or something, and then we'll have a discussion on the case, and we'll be winding up. So we'll move on with the session, and I request Smriti ma'am to kindly take over.
Thanks, Manisha. Is my audio coming through okay?
Yes, ma'am, it is.
Okay. All right. Hi, everyone. Nice to see you all. And welcome to this session, which is on the psychological impact of pain. I'm very happy to introduce you to our lead facilitator for today, Dr. Aju Mathew. Aju is a medical oncologist, and he's been somebody that he's been a good friend of Pallium India's for a while now, and he's currently with the Ernakulam Medical College. And I know the Malayalis on this group are probably going to be very upset by my pronunciation, but Kolansheri Medical College. So yeah, and apart from that, I know for a fact that a lot of people consult with Aju, and every patient or every family that I have been who I have facilitated consults for have always come back and remarked on the very human approach that Aju has. And he has the innate ability to look past the disease at the person and the family. So very pleased to have you here, Aju. Over to you for the day. And just to give you a bit of a heads up, it's a very eclectic group that you're addressing. We have social workers, counselors, we have cancer survivors, we have caregivers, we have hospital administrative staff, as well as doctors. So I'm sure we'll all have a very enriching session of mutual learning. All yours, Aju.
Thank you. Thank you, Smriti. It's a great pleasure to join all of you as you participate in this ECHO training session over several weeks. Before I start, I have a quick question to the organizers, Rajlakshmi. Do you have the slides, or should I have to, would you prefer that I run it from here?
So what do you prefer, sir? If you wish to run it from there, you can do it.
Can you yourself?
Yes.
Yeah, thank you.
So while Raju is setting that up, Aju, I'm also just going to take a minute to run through some housekeeping rules with everybody. We use the chat box a lot in this particular model of teaching and learning. And as your co-facilitator, Aju, I will be addressing questions or comments that arise in the chat box and summarizing them for you from time to time. So whenever you feel like stopping and taking up some of the discussion points that are appearing in the chat box, do let me know, and then we can free flow between discussions and didactic as we go along.
All right. So this is not going to be didactic. So just it's an interaction. It's hardly 50 people. I mean, even if it's 100, I can easily have a conversation with each one of you. It's a unique skill that I've acquired over the last 100 years that I've been around in this planet. I'm just kidding. All right. It's great to see everybody. Palliative care and Pallium India is is in my blood. It runs. In fact, pain and comfort. Comfort is my priority to my patients and to everybody around me. So even outside of being a doctor, I try my best to make sure everybody is comfortable around me and with me. And pain and its impact, as the title of my talk says, it is not very difficult for every one of you to figure out what its impact is. Next slide, please. And next. And the answer is it's bad. There's nothing that can be as disconcerting, as problematic for a person, for a family, for a society as is pain. And as a cancer doctor, I am in constant agony and constant battle with this 4-letter word, pain. Every single one of my patients have some kind of pain, which I will come into in just a bit. We call it total pain. And every single patient of mine have some way they're impacted with their disease and as a result, having something that concerns with my talk today. Next slide. So in brief, you can think of the impact of pain in three ways. One is physical well-being, two, the emotional well-being, and three, the social well-being. Physical well-being is, you're just tired, you're hurting. Emotionally, that will transform the way you deal with yourself, the way you handle yourself, your emotions, the emotions in your family, in your social setting. Social well-being is how active or how involved you are in your society. So pain impacts every level of your well-being. Next. What is pain? It is a sensory experience. If you ask anybody, they will say pain. Oh, എനിക്ക് വേദന എടുക്കുന്നു. I hurt. Uh, it's a sensory experience. But you ask me, I can tell you that as much as it is a sensory experience, it's an emotional experience. But in reality, pain happens primarily because there is some kind of an insult that is happening in your body. There is some kind of a tissue damage. How a patient responds to that insult, the insult as in a physical insult, is dependent on the person, his or her tolerability, their experience of pain from time to time, from person to person, it varies. But one thing next slide, one thing that we as doctors, as healthcare providers, as social workers, nurses, survivors, advocates, we need to understand is that we have to believe what the patient says. So pain is what the patient says it is. If the patient says it hurts, it hurts. Now you may have your opinion saying, when I was in medical school, our teachers used to say it's an upper story. Generally, they would have a condescending attitude to some women when they walk into the clinic with some complaints and say, in apparent symbolic language to the students surrounding the doctor, it's an upper story problem, as though it's a problem in the brain, it's a problem in the mind. But in reality, how much of you want to blame something on emotional cues? Uh, the reality is, what you have to believe what the patient says. Different people show pain in different ways, so it's a subjective experience. Different people experience pain differently. So one person's report of severe pain may be maybe nothing for another person with a greater tolerability, with greater social support. Now, our challenge as caregivers is to assess all the relevant factors. That is the person's well-being, emotional well-being, the social support, the access to resources, everything. And then use what the patient tells you to provide care. And most importantly, we must do our best to not impose our personal biases. So, those who are listening to me, you may have your own ways of looking at pain. You may have a low threshold to pain, you have a high threshold to pain. You may not take a paracetamol when you get a headache, but I do. You may want to just sleep it over, but I do want to take up medicine. I can't sleep without taking a paracetamol. So, our personal biases should not impact in the way we give care to somebody with pain. So what is the most reliable indicator of pain? Next slide. It is a person's self-report. Various psychological factors may modulate it. Emotions, cognition, um, somebody with a greater understanding of what is happening in their body in terms of disease progress, in terms of the disease process, the biology of the pain may respond to pain in a different way as someone who don't understand intellectually what exactly is happening. The personality may play a factor. Coping techniques, some may use meditation, some may pray, some may watch a movie. When I was ill with a torn ligament, one way I had significant pain despite having a pain pump. One way I coped, me and my wife actually, she was also coping along with me. Coped is by watching cartoon movies, Despicable Me being one of my favorite. And as I was watching Despicable Me, Gru, the guy who plays the main character, uh, runs up and falls and breaks his knee. So it was kind of funny. I was having pain, but at the same time, I was also watching what caused my pain in the comedy movie that I'm seeing. So different coping techniques. All of us may have different ways to cope. It is important for all of us to know what people use to cope. Some may have an illness behavior. I'm sick. I just want to lie around, get over the pain while it is there. Some says, I don't want to lie around. I want to be active. So it's the experience of somebody's pain is an interplay of several factors. Next slide. But as doctors, as healthcare providers, each one of us, there are ways we can assess objectively how much somebody has pain, especially in those who don't have an avenue to express pain. Some of my patients, they are on the ventilator. Some may be bedridden. Some may not be able to communicate. I can assess how they are responding to the pain by checking the heart rate, tachypnea, that's a high respiratory rate. Someone would have a lot of breathing per minute, breaths per minute, like that. They may feel very restless. They may be crying, moaning, groaning, grimacing. You may see patients who are on the ventilator who may just grimace, who may just squint or like squirm in their face. They may show a lot of resistance to care. They may show social interactions would be lesser. They may not eat. Sleeping problem. This is one major trouble that I see when patients have pain. Next slide. So there are ways to objectively assess. Now, when pain is not treated properly, the impact of the pain on the body is significant. You may have appetite is poor. You don't want to eat. You don't want to sleep, disturb sleep. You may want to reduce your social life, get away from everybody. You may feel depressed. You may show it out as aggression, wandering, acting out. You may resist care. You may just become bedbound. If I move, I have pain, so I don't want to move around. That actually, it's a pernicious, it's a cycle. You just get into more pain, stay in the bed, get into sores, more. It's a cycle. Next slide. And this is where I want to talk about total pain. One way or the other, all of my patients have pain. Dame Cicely Saunders, who I'm sure all of you have known by now, is the doyen of palliative care. She defined the concept of total pain as a suffering that encompasses all of a person's physical, psychological, spiritual, social, and practical struggles. So as much as I've constantly been talking about physical pain, spiritual pain is also important. Someone may basically not have any physical pain, but they may ache deep within their an unmet need, an unrepentant grief, repentance, lack of repentance for their sin or for what they've done to someone else. The financial situation may cause pain. So the objective of my treatment for the total pain that my patient has is not just pain relief from the physical realm, but also to provide comfort, or in other words, to provide quality of life. Next slide. As a doctor, this is how I try to compartmentalize the pain that I see. Is it a pain that can be treated and healed? You're right, total pain can be managed with interdisciplinary intervention, as Vandana Mahajan just pointed out. And this is where all of you are equal in this in the struggle against total pain. I can't do my job without getting social welfare, social care, social services support for my patient. I can't do my job without getting spiritual care from the chaplain. So it is an interdisciplinary way to take care of total pain. But coming to the physical pain, something that I compartmentalize pain into is two ways. Is it a pain that can be treated and healed, or it is a pain that can be treated and palliated? For example, toothache pain, I don't need to palliate it. I can heal it. I can take care of it completely. Certain pain, chronic pain in patients with cancer, I got to treat them with pain medicines and palliate them. So I try to compartmentalize because that will help me address the physical part of their pain. Next slide. So the diagnosis is important. Somebody with pain, why they have the pain is important. And for that, I use a lot of examination, physical examination, some blood tests, some scans. But more importantly, I should be able to provide access to the right treatment for that particular pain. You would understand what I'm talking about in the last two slides as I will go through a few cases that I want to describe. Next slide. There are various ways we can take care of pain, physical pain, surgery, toothache. I told you, toothache is when there's an abscess in the tooth or there's caries. One way you can take care of the pain is by just removing the tooth. My mom was visiting me in the US when I was there. Around Christmas time, she had incredible pain. She tried to do her best to take care of it because she worried she didn't have health insurance in the US and it's going to cost us a lot of money. But finally, she told us she had significant tooth pain. And it was horrible for us to see her suffer. I mean, it may be the smallest, tiniest organ in your body, a small tooth, but the amount of pain a toothache can cause, I'm sure all of us have experienced it, but it was overwhelming. We took her to the dentist said, there's no way we can save the tooth, we'll just take it out. She said, please take out whatever you want. I just want to get rid of pain. Immediate pain relief. The doctor took out the tooth and immediate pain. So surgery helps. Procedures, pancreatic cancer pain. Some patients may have cancer in the pancreas, and when there's tumor in the pancreas, it impinges on the nerve around that pancreas. And one way we can take care of that incredible deal of pain is by giving a block into that nerve plexus. What do you mean by block? You can put local anesthetic medicine, inject it into that area where there is the nerve that is getting impinged, and basically make the nerve go into sleep so that it doesn't fire and cause pain. Medications. There are topical medications. Even today, I prescribe fentanyl patch. There are DFO gel. That's a pain gel, Tiger Balm for some of us, Volini for some of us. Parenteral, there are oral ways. There are IV medicines. There is intramuscular NSAIDs, non-steroidal analgesics. There are subcutaneous medicines you can give. Integrative medicine is another tool that we can use for pain, interdisciplinary practice. Supportive care. If you have sustained a fracture, which thankfully I have not, uh, you can splint and brace and help reduce the pain. Immediately splinting will help reduce the pain. Splinting is you put something firm around the bone so that there is limited movement in the broken part of the bone. So there is immediate pain relief. Counseling, psychological therapy can help. Next slide, please. Yeah. But the most important way I should reiterate is to listen. And this is where I think a lot of us fall short. Doctors, especially. I practice in this field. I know that bulk of the doctors that work with me or that I share patients with don't have this attribute. They don't listen. If you can't listen, you don't hear what the patient says. If you can't listen, you don't understand what causes the pain, why there is pain, and if you can't figure that out, how can you take care of the patient? So to listen is single most important skill that you need to do to take care of your patient's total pain. Next slide, please. So the most important thing, I'll have a few quick slides. The most important things you need to know about medications: treat pain early. If patients are having continuous pain, for instance, cancer pain, you got to have analgesics, which has to be given on a continuous schedule and not just when it hurts. There is a stepwise approach, analgesic ladder. Next step, so you can escalate the next slide. You can escalate the amount of pain medicines that you want to use based on the intensity of pain. So at the get-go itself, I will not prescribe an opioid like a morphine to a patient with pain. I start, especially with a non-cancer pain, I start with paracetamol. That's why I said paracetamol for headaches, and then step it up to maybe an NSAID or non-steroidal anti-inflammatory drug, and then maybe something which is a schedule to tramadol kind of non-opioid medicine, and then probably an opioid. So there are different ways we can step it up. Next slide. And now I'll come to my last part of my talk, which will be 5 cases. These are real patients who I'm not going to describe too much in detail, so they're anonymized. I will hide their qualifying information so nobody can identify them. But these are real patients, these are real situations that will just illustrate how I help manage pain. One day I was actually seeing a patient in my cancer clinic. It's a patient I know very well. who I take care of her cancer, her pain, a total pain. And then the husband said, "Hey, my maid has a headache. My friend, the doctor said, let's do an MRI. Would you mind writing for an MRI scan?" I said, I am happy to write for an MRI scan, but it would be better if I actually talk to the maid and maybe even examine the maid. So thankfully, the lady could not walk well, so the maid was with them. So he said, "Oh yeah, she's sitting outside. Let me bring her in." I said, "Let her come in." She came in. I spoke to her. She said, "My headache is there. It's very intense. I wake up in the morning, my head hurts. So let me examine you." And I simply press her sinuses, and it hurts. There's tenderness in the sinuses. So I told the patient's husband, that's the person responsible for this maid, that let me give her some antibiotics, paracetamol, and let's see if the pain doesn't get better, then let's take care of with a scan. And lo and behold, the headache improved within a few days. It was just plain simple sinusitis, and the intervention would have ended up in an MRI scan, cost, time, a lot of things, but with a simple conversation, a simple physical examination helped me understand and treat and cure that patient's pain, which is a headache from sinusitis. So you see how uh, compartmentalizing to pain that can be treated and cured helped me figure this out. You see how pain that can be examined and obtaining physical signs helped. So this is one instance where we actually have to use our skills, physical examination skills, talking skills, understand why a patient has pain and figure out what can we do. Let me just read what. Oh, okay. All right, no problem, Surya. Okay, next slide, please. The next case is a patient with metastatic breast cancer with intense headache. This is a patient I know for a year or so. Patient called me from home and said, "I have intense headache. I tried a lot of medicines, paracetamol, NSAIDs, everything. There's no response." I said, "Can you come in?" I'll try to come in, but it's going to take me some time because I don't have anybody to bring me there. Um, I said, then I went through the differential diagnosis. Patient with metastatic breast cancer with intense headache. It is likely that they have cancer in the brain. And the cancer in the brain causes swelling in the brain, and that causes headache. So the immediate thing that I can do is to give her something that can reduce the swelling in the brain, and that may help her headache. So I said, okay, while you wait to come to my clinic, why don't you get dexamethasone? It's a steroid, and take X amount, whatever milligram I told her. And by the time she came in, she said, "Hey, my pain is almost gone." Unfortunately, she ended up having cancer in the brain that caused the headache. So this is where I compartmentalized into a pain that can be treated and palliated. Now, this patient has breast cancer in the brain with brain metastasis causing swelling in the brain. I took care of a pain by giving a steroid. So there are ways, not just pain medications. There are adjunct medications that I can use that will help somebody's pain improve. Next slide. Patient with stage 4 colon cancer, history of colon cancer. She's already had surgery, but with pain in right upper quadrant and left lower quadrant. So basically abdominal pain. This patient complains of pain, constant pain, but I'm seeing her for the first time. By the time she came to me, she was emaciated, but significant pain. The doctors have been giving her pain medicines, whatever they could get a hold of, but nothing had helped her pain. There's one simple thing I asked her that helped me address her pain. I asked her, when was your last bowel movement? She said, "Oh, I don't recall." So about 5 or 6 or 7 days prior to coming to see me was when she had a bowel movement that was small, tiny bit. I mean, I can do an X-ray and prove it that she has stool that is impacted all throughout her colon, but it was obvious. I gave her an enema and her pain improved in no time. So all cancer pain doesn't need to be because of cancer itself. It could be a result of the medicine that we give her, uh, because some of the medicines that we use for pain, for cancer, constipates. And if you don't actively intervene and address that possibility or that risk, then you may end up with pain from all sorts of issues, constipation, for example, in this case. Next slide, please. Now, this is another patient with brain metastatic cancer, breast cancer in the brain. But the daughter came to see me. This is a patient of mine. But the daughter told me that there is a lot of family dynamics. The husband doesn't take good care of the young lady with brain metastatic cancer. He's a very busy person. The daughters are giving the care. But there's a lot of the patient is on high levels of pain medications, fentanyl, morphine, everything, but she is grimacing all the time. She's sad, she's depressed, and I could see that there is a lot of issues going on at her home. Now, this patient could not come to see me because she was in that kind of a significant discomfort, but I go see her at her home. I take her family members out of the room. I said, can I have some private time with the patient? I spent some time with the patient. We had a conversation. We didn't directly address her cancer. We talked about a lot of things, but slowly she opened up and she said, there are things that I am worried about in the family. There are certain things that I need to figure out, certain things people I need to forgive. I could see that there's a lot of spiritual side to her unmet pain issue. I am being a Christian and she was also Christian. I could immediately offer her a prayer at that time itself. And you won't believe it, it was really remarkable. She experienced remarkable transformation from that moment on. Uh, this is something that can be addressed through a chaplain, through a doctor, through a family member, through a friend. Spiritual support can probably help pain relief. She survived for another week, but that 1 week was the best week for them. The daughters just sent me pink cupcakes just a few days ago in honor of how I took care of them. Uh, they said it was the best few weeks they got with their mother, and they could take care of her at her home. But just I could have increased her pain medicines. I could have given her more morphine, but that would not have addressed her comfort. So total pain requires understanding of both um, the physical pain, the spiritual pain, the social pain, the financial pain. A lot of us can't take care of the financial pain because we can't pay for every patient's financial difficulties, but we can offer them whatever we have avenues to offer. Social workers can help us out. At the bare minimum, we can give treatment that is in tune with the financial condition of the family and not bankrupt them. And that is also important in taking care of total pain. Next slide, please. And this is another instance where a man with prostate cancer who got chemotherapy and now essentially is cured, but can't sleep. I said, why can't you sleep? Have pain in the feet. On further prompting, I could figure out that he's having neuropathy, which happens because of chemotherapy. And he also had diabetes. So I started him on a medicine that can not cure the pain, but can palliate the pain. The moment I started the medicine, he said, I'm experiencing slightly improved neuropathy pain in my fingers and my toes, but it still hurts. So I could sense that at the lowest dose I started, it's responding. So I increased the dose. So one medicine doesn't probably help. You may have to meet the patient again and increase the medicines and maybe talk to the patient and support the medicine. And finally, the patient was able to sleep comfortably after I addressed his pain, which was neuropathic pain, and palliated it. The patient is cured, but the pain is not something I can cure, but I can still palliate that patient's pain, although the patient's cancer is cured. Next slide, please. What are the barriers to giving good pain control from all of us? What are our barriers? One is patient tolerance. Some patients don't like to admit that they are in pain. That's a challenge. So some patients have very poor tolerability. That's a challenge. And then you'll have to give them high degrees of pain medicines. and that will eventually give us more symptoms like constipation. So one of the key barriers is patient tolerability and patient willingness. Another barrier is caregivers. We impact uh, a patient's pain control by positively or negatively by bringing in our own biases into this mixture. Financial resource is a significant barrier. I've been mentioning fentanyl patch to a lot of people, but fentanyl patch is not something that's very affordable for a lot of patients. One patch, which you have to change every 2 days, sometimes costs 250 rupees. So morphine is something that is cheap. Some patients don't want to take it. Some patients don't want to take a PO or a pill. So financial resources are important. Some patients don't have money to evaluate or address pain, the reason for the pain. So financial resources are a significant barrier. And finally, one of my pet peeve is the resistance from doctors. There are very little incentive to taking care of pain. Prescribing chemotherapy gives me a lot of incentive. It gives me a self-satisfaction that I'm doing something that I'm trained to do. It gives me money, whatever. But pain medicines are cheap. There are really no great incentive other than giving a patient comfort. Ignorance. A lot of my patients, my doctor friends, have a lot of ignorance about pain medications. If you still ask a lot of doctors, just go talk to your doctors and ask them this simple question: on an average, what is the maximum a patient can take morphine? What dose of morphine can a patient take? What is the maximum threshold? Just ask this question to a doctor friend of yours, and you would hear all sorts of answers. The correct answer is, well, I'll wait to see what you would tell me in your chat box. I'm not going to give you the answer. We have time. Remind me if I forget to address this question. So the question that I want you to ask your doctor friend is, what is the maximum morphine you can give to a patient in terms of milligrams? I'll look forward to what the correct answer would be. Next slide. Here's where you can help. Okay, Mouse to me already has answered, so I'll save everybody the time to type. The answer is correct. Dose at which the patient gets relief is the correct answer, is the correct dose of morphine. So if a patient gets pain relief with 10 milligrams morphine, that's enough. If a patient requires 900 milligrams morphine a day, which some of my patients were on, then you may need to give that much. So there is no ceiling, there's no threshold. So most doctors don't realize that, don't understand. Here's where you and I can help. I should add the word I. Listen to patients. I told you, listening is important. Talk to patients, family members, caregivers. Emphasize that multidisciplinary care is important. That is important to address total care. Ask questions. Leading questions are okay. Are you in pain? Can you sleep? How much pain do you have? Can you score it on a scale of 0 to 10? Ask. Don't underestimate pain. Don't underestimate pain, because pain actually impacts completely. Next slide, please. And that's the end of my talk. Thank you. I would just like to address a few questions that have been asked in the last few minutes. Pseudo pain can exacerbate. Please say something. Is there any pseudo pain? I don't know what pseudo pain is. Seriously, I'm not sure. I don't subscribe to pseudo pain. I don't know if it's a described thing. I'm not sure. I'm going to say I don't know anything about pseudo pain. Sorry. I don't think there's something called pseudo pain. Financial issue plays a very important role. You're right, Mausumi. It is an extremely important aspect of addressing pain, evaluating pain. You're very right. John Burgess, understanding religious aspects or impact of sickness, pain, and the religious aspect of pain. A lot of patients, you may think that those who are spiritual may not actually have more pain. In fact, I've found the other way around. Those who are really spiritual will probably have a lot of pain because they are able to voice the pain better. Our spirituality, our religions always talk about pain. So people who are more spiritual are able to describe pain better. That's my understanding. A lot of people who feign ignorance of spirituality sometimes aren't able to describe the pain. But spirituality doesn't really have any much correlation. Unaddressed spiritual needs can increase your pain. And it's a reality. Now, as I've explained in one of the specific cases that I was just talking about, this is not just one case. I've seen numerous cases, patients, I shouldn't say cases, but because we're doing a case study, I'm just going to use the word. But I've seen numerous patients of mine who've had a spiritual part of total pain, of in issues at home. Just recently, I'll just give you an example. Just recently, I had a patient with lung cancer. His son doesn't talk to the father uh, because of some issues that happened around the time of his marriage. He decided to marry outside of his religion, and that didn't agree with his father. Father protested, but just for not a serious protest, he said, Monet, should you think again? But that he got very aggrieved by that. And despite the fact that the patient has cancer, the son isn't in very good contact. So I had to call the son up. But I can't give him the understanding that I know what is going on. So I just explained that the father has only few days left, few weeks left. That is very important that you go talk to him, or else you will end up with guilt. And finally, that happened. In fact, on the day the patient died, the son was with him by his side, holding his hand. So, and he died a comfortable life. So, spiritual part is very, very important.
And just
And
to cut in there, Aju, I just want to also clarify to the group that when we speak of spiritual components, we don't only mean religious. So spirituality means different things to different people. And it's really what brings you meaning, a sense of connectedness, a sense of purpose, a sense of hope. So for some, it could just be art and music or nature or whatever. So just to sort of explicitly state that when we do talk about spiritual concerns, we are not purely, the religious aspect is only one portion of that entire domain.
yeah, in this case that I was talking about, it was not about the religious aspect of spirituality, but in this case, it was about a father-son relationship.
Yeah, exactly. Sense of connection.
Yeah. Um, am I missing any questions?
So there was one interesting point that Rajni is also a doctor, by the way, Aju, and she talked about chronic pain and how lack of history taking sometimes exacerbates pain. And to her point about chronic pain, I think there's also, after a while, when someone is experiencing chronic pain, we find that that person gets stigmatized quite a bit. Because if there's no tangible sort of source or reason for that pain to exist, and the person's constantly complaining about it, I think it becomes, there's a bit of fatigue that sets in with the caregivers and all of that also. And I think Dr. Raj and all of us have talked about it so much that people with chronic pain sometimes become marginalized because if it's not treatable in the usual way, then people tend to relegate it to the, okay, it's like you said, it's a upper story or a top story problem rather than a real thing. So would you like to comment on chronic pain a little bit?
It's a very challenging situation, chronic pain. I particularly deal with cancer, and some patients like the one that I was talking about at the end of the patient that I was talking about at the end of my talk, a patient whose cancer was cured but ended up with chronic pain in the feet, neuropathic pain. I can still take care of that. There are ways to take care of that. But I agree that some pain is very difficult to control, very difficult. You will try all sorts of medications. Patient may not want to take morphine because it impacts their alertness. Some patients may have that. And then you may want to try interventions. Is there any intervention that I can use, like the celiac plexus block that I was talking about? Some patients may have lymphedema that causes pain. Morphine doesn't take care of that. That's a lymphedema, is the swelling in your arms that can happen after you have breast cancer surgery. And that can get really big, like huge arms, and it can cause pain. Therapy can help, but therapy can only help if it's in the early stage. Sometimes it gets that big, like elephantiasis, like filariasis, gets significantly huge. It's difficult. I don't say that I know everything about pain, that I can give utmost comfort to my patients all the time. But it's a challenge. We learn every day. We are learning. We try our best every day. Understanding, recognizing, and accepting that there are limits to which I can help is itself comforting to some patients. In patients that I was just talking about the lymph pain, me myself telling my patient, there's really nothing I can offer, unfortunately. That itself is comforting for patients.
Absolutely.
I saw another, yeah.
Yeah.
Go ahead.
Sorry, go on. No, go on, Aju.
No, I finished. I was just going to address another question. What are you going to say?
Yeah, so I was saying that, there seems to be this sort of very binary view that pain is either rooted in the physical, in the physical or in the psychological. And somehow, any pain that emerges from your emotion state or your spiritual state is somehow considered to be less important than something that has a clear and physical reason. And people tend to get brushed aside. Like even very often in the conversations we have, when someone says, oh, their pain is so psychosomatic, and it's dismissed like as if it's actually something that's made up or imaginary or something like that. But I think we're such as human beings, every aspect of us, whether it's our spiritual side, our psychological side, it's all interconnected. Just like a doctor can't just treat a kidney and not look at the person. I think we should stop sort of scoring it and saying, okay, physical pain is priority. Psychosomatic pain, I don't want to bother with that too much because it's really the patient's problem. It's nothing I can do. So there's, you know what I'm saying? There's a bit of a stigma attached to that. So can you just talk about?
I can, yes. You brought up a very good point, which I struggled. I plead guilty to this, especially pain that fibromyalgia patients talk about. We even now doctors, even myself, I plead guilty to some of my patients, not patients, my friends, family friends, relatives who talk about, who I know have nothing physically going on, but they complain of pain here and there and fleeting. I have this, I plead guilty. I mean, I just mock her in my mind and say, oh, it's just upper story of psychosomatic. But the fact is, doctors, care providers, each one of us, we have to be humble that science can only describe what we know based on technology that we know. People didn't know what H. pylori causes to the stomach until a microorganism called H. pylori was diagnosed, was studied, and finally somebody got a Nobel Prize for that. We didn't know what COVID was and how to take care of it until somebody started, understanding what exactly is this. Is it a virus? Is it a bacteria? We didn't know what HIV was until we figured it out. So fibromyalgia, maybe 10 years now, 20 years now, we'll figure out a biological reason why some patients experience fibromyalgia. So I should be humble enough to understand that there are limits to my understanding. And I should, like I said, pain is what the patient says it is. I want to talk about one particular thing. Sriya talked about here. Dr. Mathew, how do we identify a person who denies pain, as you mentioned? Somebody who denies pain, it's very difficult to figure that out. But that is why I just mentioned in my talk that we have to ask questions, leading questions. Are you in pain? Don't worry, you can tell me if you are in pain. I have ways to help you. Can you sleep? Why are you losing weight? Why are you not eating? What's going on? So is it because there's some discomfort in your body? There are ways people can, you give the freedom for patients to describe their problems, then they may open up. That is the most clear-cut reason why patients deny pain is because they feel that their verbalization of their comfort or their discomfort they don't expect that the doctor or the care provider will address it. So you give the confidence to the patient that they will address it. They have the time to listen or want to listen or is keen to understand. They may say so. Otherwise, there's no way to force an answer out of somebody. There's no blood test.
There's also a cultural context there, isn't it? Some people are expected to be stoic. Some people are supposed to, like part of suffering is part and parcel of the experience, and so on and so forth. I just want to pose a question to you, Aju. Do you see any sort of, is there any gender-related stuff that you see in your practice? Because I'm asking this because a lot of the times, there's this, people very flippantly say, oh, women's threshold for pain is much higher. And there are these social constructs. I don't know if it's imaginative.
No, I can answer that very well. Cancer, that's my area of expertise. Cancer pain, that's what I see. Really, gender has zero role. But I don't know enough in other diseases whether gender modulates your pain threshold. I don't know. But in terms of pain that I see in my practice, there is really no modulation or interaction between the gender and a person's pain. But one thing is, men are able to verbalize or are more empowered to talk about it, have more access, especially if they are, especially financially challenged women have a hard time. So finance matters more than gender. financial capacity. So
yeah, so I didn't mean like anatomical gender, because there are social issues surrounding even the way people access healthcare. Like a woman will access healthcare differently from depending on the socio, cultural context and so on and so forth. So there are prejudices, like John has mentioned, and also expectations of people in different sort of contexts that they reside in. Yeah. There are a couple of questions I think you might want to take, Aju, from Sudha, and Shala from Allahabad has talked about a patient that she had.
okay, I'll first address Sudha and our Menon. We as doctors do find it difficult to manage chronic pain, as some degree of compassion fatigue does come in. You're so correct, actually. I don't know. I don't have an answer to you. Maybe you can tell me more about what you seem to get it very well. You understand it. I'm keen to hear what you have to say. Compassion fatigue is right. I have never used that word, but that is correct. Very correct. Compassion fatigue. Yeah, I don't have an answer to you, but I'd like to listen to you for a minute if you're there.
Sudha, would you like to unmute yourself and
Yeah, I'm Dr. Menon from Bangalore. I'm Director of Internal Medicine at Fortis. And this, over years of practice, this is something off late, and especially after, I think, COVID, paranoia setting in. Our threshold to handle this kind of chronic situations is becoming very difficult. I find it really, really difficult to recharge my own batteries and, give the same amount of attention to everybody who comes with me and comes to me with pain. So that's a genuine. I would say I don't know whether it's a symptom of burnout or it's a symptom of not being able to how does address everything equally. It's a serious problem, I feel, and it's something which is happening across all different branches of medicine, according to me.
You are very correct. It is burnout, no question about it. Because
Yes,
you know,
because
it is. I'll give you an example. I'm in my own field. There are much well-known doctors who practice, uh, who have much more patients than I see, who have much greater respect, who are tremendous doctors, but their patients have completely unmet pain needs. So
yes.
one is, this compassion fatigue can set in, and I'm at risk of that too. And
Yes, I think all of us will be, because, and I
yeah,
don't know, maybe these kind of fora are important because it gives you a chance to vent out without being judged, that. So you
yeah,
have tagged that you've got to be empathetic and caring and all the time, which is a huge burden to shoulder at the end of the day. Because you have to come back and like Smriti said, as women, we our roles are so different. At home, can you just shed it out of the out of the door when you enter? No, you have to sustain that, and it's getting difficult for everybody. And this is something, like I said, it's not just in terms of
yeah.
say internal medicine or even the surgical branches.
Yeah,
These are
I'd like to differ with you on that. Women coming home, men coming home too. We also.
no, it was not a gender bias kind
No,
of
no,
thing.
no, no. I'm just kidding with you. The fact is, I
Yes.
want to talk about that. Men cry. I cry for my patients. So men sometimes there's a saying that men can't cry. Men cry. I was just chatting to one of my colleagues here in Ernakulam. We were seeing the same patient, second opinion, third opinion kind of thing. The patient came to see me, and I was just sharing with them. It's such a tough case, young woman with cancer, and he said, I wrote, I sometimes cry for this. And he returned the saying, I do cry. So two men, doctors, WhatsApping and accepting that both of them suffer the same trouble. So, yeah. All right.
I'm sorry. I think I stepped on a sore point right now.
No, I think one of the nice things about this platform so far has been, first of all, Sudha, I think it's really great that you brought that up. And like you said, it's nice to have a forum where we can talk about this in a manner that is not judged in any way. And here I am quite humbled and awestruck to see two doctors so openly putting their vulnerability out there. And, because sometimes even we even though we're within the healthcare system, we expect the doctors to just keep going, keep going, keep going. And it's refreshing. It's been so refreshing. Aju, for years I've been listening to you. Every single time I listen to you, I thank God there are doctors like you around, and there's, because it's nice to actually have someone like you around and then talk about your experiences in the way you have. And Sudha, it's this is supposed to be a session, like it's a non-medical foundation program, but I love the fact that there is such an interdisciplinary presence here. And I think to understand pain and the psychological and social and spiritual impact of it, the conversation that we had today, I think, is a truly interdisciplinary one. And I don't know how many people have the opportunity to have such open conversations with doctors on their teams, and or to hear back from others on their team. So I'd like to thank both of you for raising these points. Very, very valid. I'm going to just sort of segue now. One last thing I wanted to mention, which Aju mentioned right in the beginning, is to treat pain early. And I find this over and over again, that when we recommend, people ask for pain relief, they're often told, you're not there yet. It's, why do you need to start on the opioids? You're not there yet. So there seems to be this thing of pain has to be unbearable before you ask for relief. And that, I feel, is something that we all need to be cognizant of, that you don't have to get to that point, right, till your life is falling apart around you as a result of your pain, and then you deserve pain management. So Aju, the final thoughts on that before we move into the case presentation?
No, I completely agree with you, and I really don't have anything more but to say that untreated, unmet pain issues are probably as important as any medical problem or any social problem that we see. You may talk about drug abuse as a social problem, but I see more people with unmet pain needs in society right now than I've seen drug abuse. It's probably there, but this is something that is unrecognized. People don't see this as an important thing, that all of us need to join hands. And that's where, Smriti, your articulation in some of the talks that you give helps all of us take this movement forward. Rajagopal sir, Pallium India Trust, and the ECHO program, Rajalakshmi and your team, you've been very accommodative. I had to postpone this talk to another time because my father-in-law was in the hospital with COVID. We had 6 weeks in the hospital. He finally survived and came back home yesterday. And I'll give you one brief thought from my 6 weeks of COVID experience in personal life. My father-in-law is 82. He was having COVID pneumonia, took to the ICU. And while he was in the ICU, there was no way nobody could see him. But I used my doctor privilege, went to Trivandrum, wore all the PPE, walked into the ICU with my mobile phone, didn't ask any permission, WhatsApp video called, showed my father-in-law to my wife, her son's abroad, daughter-in-law's abroad in the US, used it up. It was the most precious moment for all of the family to be able to see the father in the ICU. For the father too, it was good to see them, although he was not in full sense. Now, how did this impact my immediate empathy? I could see what I was going through. Next day, I was back in my practice, and I was called to consult a man in my Kolanjeri Medical College ICU. The gentleman was in respiratory discomfort because of cancer. He was sort of struggling, but his daughter was abroad in the UK. So she wanted to talk to me. Her mother was giving me the handheld device, which has internet. She was giving me a WhatsApp call. We spoke. I gave her the answer to a lot of questions. And then finally I asked her, do you want to see your father? She said, oh yes, I would like to. So I just walked in with the gadget. All the nurses were, what's going on with this guy? And I took it there, video called the daughter, showed it to the father, and the father was so thrilled. Mola, I'm fine, she said. I'm fine. I don't have any problem. But he was actually on a big breathing machine, struggling. And the daughter was tears, and she was grateful and thankful for that opportunity. But so how all of us have these shared experiences. Sometimes the way we grow up, the way we interact and understand, only when you walk through it, you understand how important it is for somebody abroad, a family member, to see what is happening. So I could immediately translate that into my patient's practice. Now I'm better tuned to understand how much COVID impacts families. A week ago, one of my other patients was dying in the hospital with COVID pneumonia. His family called me and said, is there any way you can send us one picture from inside? I said, I'll get you inside. Only condition is you all have to wear PPE. So I managed to get them all in with the PPE. And they just called me a few days ago and said that was the best gift they could give. You got to advocate. None of the doctors there advocated because they have never experienced COVID pneumonia in their family. Now I had. I knew what it means. So I was able to advocate. I'll stop here and I'll let the next session move on.
Yeah. Wonderful. Thank you, Aju. I think you've made a huge impact on a lot of people today. There were a couple of medical questions that were asked, which I think this may not be the most appropriate forum. So we're going to take those questions and email them to you, Aju, for your inputs on them later, if you don't mind. And just before we go in, you brought up an issue of addiction and drug abuse and stuff. I just want to take a moment because that's a very, very important issue you raised. One of the biggest reasons we don't, I mean, there is opiophobia and there's also opio ignorance amongst the medical fraternity. And I think we hear a lot about the opioid crisis in the West, and we seem to think that it's a very one size fits all. It's not. The origins of the opioid crisis in the West are entirely different. It's a bit convoluted, but it's not something that we're at risk for in India, the way things are at the moment. In fact, we have the opposite end of the spectrum problem. We don't have enough access. And so what we advocate for through Pallium India's national outreach work is for balanced access to affordable pain relief. So not just any pain relief, because like Dr. Aju said, fentanyl and stuff are things that people can't afford. And we don't want to inflict more financial pain on somebody by prescribing drugs that are so expensive that they have to mortgage their homes to get it. So what we follow is something that's called the principle of balance. The principle of balance looks at international laws which look into criminal justice. And those are the laws that go after drug abuse, diversion, misuse, things like that. And then there's the laws of the international human rights laws, which tells you that all medicine should be available for medical and scientific purposes. So really, the public health is balanced on balancing these two laws. And that's called the principle of balance. And I'm happy to talk about that in further sessions. We will be addressing the principle of balance and how that plays into not just policy and legislation, but also as a human right to pain relief. So I'm going to stop with that, and I'm going to request Alpa to please come forward with her case presentation for today, and we will reconvene after. We will come back online once Alpa's presentation is done. As in, we're still here, but we'll take some
Thank
questions.
you, Smriti. Thank you, Shruti. Can I start?
Yes, ma'am, please.
Yes. Yeah, second slide. So this is a patient, BV. She was 28 years old when I met her. She was in a lot of pain in the left leg, and it was very much unbearable. And the doctor wanted her to, it was in her village that she consulted during a camp. And the doctors wanted her to go for further tests. So from her village, she went to the nearest city, Bijapur, and there she consulted. And later she thought it was a fracture, but unfortunately she had to travel to Bangalore, and then the test revealed that she had osteosarcoma of the leg in the first stage. So the surgery was to be performed, and before that I met her as a counselor there in the hospital. Yeah, next slide. Okay, so the patient was informed after the test, and she had come in a hurry. She came with her mother and her 3 little children. They were in the native place along with her husband, and she did not want anybody to be talking about her disease or anything. So even the medical team also agreed with that. And on diagnosis, she was aware that she had the osteosarcoma of stage 1. The family was unaware. The information was polluted by the medical team and the patient from her mother and the rest of the family. Family thinks she has a severe health issue, but not aware of the details. She always kept telling them that I have some major health issue, but I don't want to share it with you all. So that is when I met her, I told her, now this is the time, you please call your husband, make some alternative arrangement for your children and see that he comes over. Later, he came the next day and I had to explain in depth the facts of her case. She was worried. The patient was worried all the time. She thought, if I tell this to my husband, he may disown me, he may abandon me and my children. And where will I go with 3 children around? And that too so young. One is 8, one is 5, and another is 3-year-old. So with these 3 children, I cannot go anywhere. And with one leg gone, I really don't know what I'll be doing next. So that was the reason she didn't want to share it with her husband also. But the husband was so accommodative. He understood the fact and he said why she has to go through so much pain. She could have told me in the first instance, and I would have taken her to the best doctor and the best. So that is how the husband also supported her. The patient was aware of the prognosis and that family does not know the outcome of the disease. The information was colluded even there. Then about palliative care, this patient, through other patients, she had heard about palliative care. And the family spoke about the disease to others. So for pain management, she was there just before the surgery and I was talking to her. And later it was explained to her in depth and the pros and cons of the surgery. Next slide. So the genogram is the patient with her husband. He's 35-year-old with 3 children. One is 8, one is 5, and other one is 3. The patient has a father-in-law who's retired, a 70-year-old, and patient's parents, age 50, 55 and 60.
And thank you, Dr.
So,
Mathew.
this is the genogram of the family. Next slide, please. So the family history, she's married for 10 years with 3 children. Husband is a farmer and they have a small piece of land, which is their only source of income and living. Her parents are in another city nearby. Healthy relationship with family, parents and in-laws. She did not have any relationship issues. Only thing is she had all the unknown fears in her mind. She thought, what if they will disown me? What if they will not accept me as I am without one leg? How will the society take care of me? And all those questions she started getting in her mind. Next slide. So this is the eco map. The NGO we spoke to also, through my contacts, I spoke to the NGO and they promised her once the surgery was done, they will help her with the artificial Jaipur foot also. Of course, the temple authorities in her village, they may not accept her because she has pain. That is what was her thinking. And as a counselor, I've been supporting her right from the day I met her till 1 month's time. She was in the hospital, first managing her pain and later surgery, and post surgery also she was in the hospital for a few days to recover. Even her in-laws were supportive. So everyone in her circle were very much supportive. Only doubt she had was the local community may not have, but these were all her unknown fears. Actual thing was not that. After she reached the village back, she said, no, everyone accepted me the way I am or the way I became post my surgery. Next slide. So socioeconomic overview. Here, the patient was worried, like I'll have a lot of post-operative expenses. Luckily, this patient, since it was done in a camp in her village, later her treatment was done in a corporate hospital in Bangalore. So all the expenses were done free. It was a complimentary surgery. It was performed on her. So she did not have to bear any expenses except for the accommodation what her husband and mother had to stay in Bangalore. So that accommodation plus the to and fro travel. So that was that way she was very lucky. But post operative, she was wondering whether she'll be able to get the Jaipur foot or not. I made 2 attempts with Bijapur and Hubli to get her the Jaipur food, but somehow she went very late for the measurement and other things. So unfortunately, today she could not have that foot in her leg fixed. But of course, she is using crutches and the walker, and she's comfortable and she's fine. Regular basis, she calls me up at least once a month minimum. She makes an efforts to talk to me. Even today, it's more than 7 years, but she's still in touch with me. Earlier she had a tragedy in her family, so even for that counseling she had contacted us, and I've done the needful to her. Her husband is a sole breadwinner, but he says, if my wife is alive, then I can win any war and do my earning. So she need not have to worry on that. And as regards disability benefit, she got the all she we approached the Handicapped Society and got her that membership or whatever the procedure was there, and she is eligible for all the pensions and other things. Then she was wondering whether again this will come up or resurface. But luckily, since it was diagnosed in the first stage, no such thing has happened so far. And smoothly, she has sailed the journey of 7 years. And children's education and future. Currently, the children are doing well and they are going to the government school. So all her things are in place and smooth. Next slide. Psychological distress. As I had mentioned, sitting in the hospital corridor, looking at other patients around and discussing and talking with them and taking their fears also by her stride. She thought, how will I look? First thing was the physical appearance. Then second one was whether her husband will accept her the way she is or way she will turn out to be, because she may not be able to walk normally as she had been doing. Later, she thought whether she'll be allowed in the village temple or no, whether she'll be allowed to attend functions, marriages or no, whether she'll be invited for them or no, whether her immediate family members will they accept her or no. Even marital life issues, she was thinking that her husband will definitely get married to another woman, he will leave me and go. But no such thing has happened, and he is a very caring and loving husband. He helped her very well and they're doing very fine now. Next slide. So physical acute thigh pain, especially while walking. This, she was having pain and she was unable to sit or squat. Then later she had a fall, and that is when the camp was happening in the village, she was taken there, and later the doctor said, and she had to go to Bangalore for further treatments. Psychological, she was wondering if she will have this swelling permanently along with her pain. So again, here also she had been imagining things, whether the swelling like an elephant foot, her foot had grown that big. So she was thinking, will I have to live with this foot all my life? Why all these things is happening only to me? Is it my karma that is happening? Or why I have to bear all this pain now? Then socioeconomic. This is once the diagnosis was done, and when it was decided that she had to be amputated for her leg, then acceptance at home front, as I already mentioned, will her family accept the way she is? Whether her children, will they accept the mother in this condition, will they not get scared? Because the younger child is just 3 years old. So that fear she already had so much in her. Then acceptance at society level, whether the society will accept her the same way. Will she get the recognition as a normal lady in the society, very active woman, or no? Will she be able to save for her daughter's wedding? She was wondering whether all these expenses will take away my savings for the years, because I have not one but two daughters and I have been saving slowly for them. So will all the expenses take away for my surgery and other things? That she was worried. But luckily, no such thing happened. Later, she had this question in mind. She keeps asking, is this genetic? Will my children also get? Will they also go through? I said, no, this is not necessary that it will happen. But of course, we have to be uh, keeping a watch over any health issues if your children develop in the future. But currently, no. Then spiritual. Is it her karma? Did I stamp over any mantra? Or did I do anything wrong? Or is it because of my past karmas that I have to put up with all this? And one more interesting thing she asked is, will I be born handicapped in my next birth? That much fear she had. She didn't know how to ask the doctors. So that is when she asked me. She said, Madam, she asked me in Kannada, Punarjanmadalle nange kaal baralva, like, will I not get my leg back in my next birth also? She was that much worried. Not this birth, but she was even preparing for the next birth, and she wanted to be beautiful and young. So these were her total pain concerns. Yeah, next slide. So initially it was rapport building with her. And one more good thing is I could communicate in her language very well. So I could speak to her and her mother as well. And later I requested that I speak to her husband also and explain to him the importance of him coming over. So that is how I could communicate to them. Also, I belong to the same place as hers, so I could relate much with her in so many other aspects also. Knowing about her, her family and her society background, that could connect with her easily. Then understanding her level of pain, she would explain to me every time, like, this is my level of pain, like 2 or 3 times before the surgery that I met her, and she would tell how it was and what it feels. And she shared all her worries and concerns, each and every worry. And I had shared her number, my number also with her. So that is when she told me about how she could share as and when her worries came to her. Just a minute. Then discussing about major lifestyle changes. She also discussed with me what all changes she will have to make through and how she has to prepare for the same. How she has to prepare for the same, what all changes, because if one leg goes, what all she will have to face, how will she look like, first the beauty part, and later how she will have to manage with her walking. What if the leg does not fit her, or what if she cannot move with the new artificial limb, or what if the she's not comfortable with the walker. So many small things, but she definitely made it a point to share it every time as and when she got such questions and worries. Yeah, next slide. So now let us discuss what psychosocial issues may be linked directly to the patient's experience of physical pain. So will somebody be answering this?
So we're going to invite all our other participants to share their opinions or their perspectives on this particular question. And bearing in mind the previous presentation and previous talk that we heard by Aju, if you could link the two and perhaps tell us your thoughts on this particular question, that'll be great. What psychosocial issues may be linked directly to the patient's experience of physical pain? Manisha, I think we can stop sharing the screen once everybody's had a chance.
Yeah. So the disability adding to her woes because acceptance in the family and the society would also add to the psychosocial, aspect of the pain.
So there are two things here. One is the, like we say in total pain, it's also the circumstances of the person's life that contribute to their experience of subjective physical pain. That's one. But the other, what we're asking here is the reciprocity of that, where if I'm in pain, then how is it impacting the rest of my life in that sense? I mean, obviously it's a cycle. So the question goes both ways. Aju, feel free to chip in.
I think what Ms. Dharamshi showed in one of her, I think the 10th slide, all of those are very important in terms of accentuating, increasing her pain. Most importantly, somebody here mentioned is this the future uncertainty, physical appearance. I think in the chat box, there's a lot of interesting responses to your question, Mr. Ramshi.
Yeah.
Avtar writes about future uncertainty, physical appearance.
Yes.
Sunita talks about, is this my destiny, fate?
Yes.
Anxiety, basically, future uncertainty, in other words. Fear of being abandoned.
Yes.
All of this actually adds on, feeds on to the pain. And as you can see, there is no one medicine for any of this.
I thought it was very poignant when she was concerned even of her next life and of being born,
Yes.
you know, and the thing of wanting to be born whole the next life. I don't know if it was so much about aesthetics as it was more about, am I going to carry this with me physically? And while, you know, it's different cultures. Now, Rajni had asked, does the psychologist have to be of the same ethnicity? I don't think so, because this is something that is pretty universal. And while the idea might be, quite different from what we were raised to believe, that's her concern. That is one of her biggest concerns. And like Dr. Aju said, pain is subjective. If someone says there's pain, there's pain. Similarly, if someone has a fear, it is their fear. And I don't think, it can be dismissed. So how would you answer a question like that? Even if that was not your, it didn't come from your school of thought. That's not an easy question, not easy spot to be put on. But how would you answer something like that, which would not disrespect her personal worldview or spiritual values, and at the same time give her the kind of reassurance that you as a healthcare provider might want to give her? So that's a question I'm just leaving open for everybody.
It's a very tough one, Smriti. I don't believe in rebirth, but if somebody talks about will I be having the wholeness when I'm reborn, I don't know how to answer that question other than, I mean, me saying I don't believe in rebirth is just being rude in that juncture, I think. But I like Sriya mentioned in the chat box, I agree with her and I concur with Sriya's views. Ms. Dharamshi, you've taken exceptional care of this patient. I don't think, I would have given even an iota of that care as her doctor if I was her doctor. I think more than the treatment that she got from her doctors or the nurses. This was probably even more vital, that allowed the doctors do what they had to do. Because I don't think they would not even get the patient to treat if you hadn't taken care of a lot of the other issues.
Yes. So because she had so many questions, and that is why the oncologist suggested that you start with the counseling from day one only. And she could connect with me very well, and that's why she started asking me each and everything, whatever thoughts came in her mind under the sun, and she would discuss it with me for a long time. Actually,
It's truly remarkable that the kind of information she shared with you, it comes from a place of feeling comfortable.
yes.
So I'm just echoing what Aju and Shreya have also mentioned. I just want to come back to that uncomfortable question, Aju, where, how would you answer that? My take on it would be to actually bring bring our sort of honesty to it and say that I don't know how to answer it. I'm not sure how to answer that question, because maybe, that's not something I've thought about before. But why explore that fear more? So tell me more about what made you think it. And I think that will bring up issues related to disfigurement, fears of disfigurement, fears of all of those things. She's a young woman, and it's not a matter of vanity. It's not a matter of any of those things. It's a matter of her functionality as much as it is of anything else. So I think eliciting those kind of questions through what she has brought up spiritually, and be okay to say I don't know. I don't think we are expected to have answers to everything, and that's something we need to be kind to ourselves about, because that's a boundary that perhaps we sometimes very sharply, we think we have to answer everything, but we don't. And I think authenticity is far more appreciated by our care recipients than something that isn't authentic and hollow. So Shreya has mentioned one of the prime principles of counseling is being non-judgmental. Therefore, we have to respect everyone's beliefs. Yes, absolutely.
One of the challenges that I have, Smriti, is to have an interdisciplinary approach to management of total pain in cancer, is to figure out how to pay for the services in the private sector. Um, Without charity, without funds coming in, how do I get a patient counselor or a patient navigator? How do I pay for the salary without actually billing for that visit? And even if I bill for a visit, like if Ms. Dharamshi was my support staff here, she probably did a lot more service than I would have given. But how do I bill for her services? Because that's a reality. I mean, we need to talk about that too, because not everything happens in charity. We need to talk about private practice. The things happen in private sector too. How do I bill? I mean, what clearly the patients will not want to be billed again, but but the fact is they need to understand that this is as vital a service. It's a challenge that I face. I don't know how to set up an interdisciplinary care team in the private sector.
But Dr. Aju Mathews, it was part of my volunteering that I do. And even now also I'm a counseling patient, and it's all complimentary only. So you don't have to worry for counselors like me who are volunteering.
No, but the fact is you are volunteering, but the fact is we have counselors who are now
paid counselors, yes.
Young people who are getting trained. There are courses opening. I have a hard time figuring out how to get them jobs.
Okay.
How to convince my administration that they are good, that they are vital.
Yes.
No, thank you for bringing this up, Aju, because while it's very idealistic and so some of the things we're discussing are very I wouldn't say idealistic. I mean, it's coming from a very human place of wanting to care and wanting to give appropriate care and stuff. But unfortunately, in the current context that we exist in, that's not always possible. And people with the best intentions do get buried under a system that doesn't allow them to possibly extend their services to the way they would have otherwise done. And that is a reality. And I'm just going to invite other people to share, if they will, how they have managed to overcome some of these. I'm sure these are challenges that everyone faces in every setting. How does one pay, or how does one make a system like this run and balance out, the two, the high cost? I mean, there's this terrible statistic that came out that 55 million Indians are pushed below the poverty line annually because of healthcare expenses. And what is the poverty line? That's a whole other conversation to have. The poverty line is actually the starvation line. You fall below it, you starve. So how do we juggle all of that in bringing this kind of generosity and this kind of competence to our practice, but being bound by the financial constraints that the systems put on us? We have 5 more.
And also, I think the need for counseling is
Yes.
not as much understood in a lot of setups. So as I work with cancer patients and
And
Thank you.
thank you all for attending. I think Raj Lakshmi has an announcement to make.
Thank you so much. Thank you so much, ma'am.
Hello, Smriti. Can you hear me?
Thank you.
In between. Are we audible now?
Yes.
Thank
Okay. So that was indeed a very good class. Actually, I have heard around 20 sessions of pain and its impact, and every time I hear Dr. Aju, it's always a new learning for me too. So thank you, Dr. Aju. So we will not be having a session coming Friday on regards to Diwali celebration. So we will have our next module on humanitarian crisis from November 20th onwards. So our next session will be November 20. We will not be having a session on next Friday. So thank you all for joining in. We will see you on November 20. Bye.
Thank you so much. Thank you, Dr. Ajay.